Hello, and welcome to the Evidence-Based Exercise Rehabilitation and Sport Performance channel. This channel is for the healthcare movement professional looking to incorporate applied research concepts into their current practice setting. Today's topic, effects of trunk positioning on shoulder active range of motion and muscular activation. The objectives of this discussion are to determine the degree to which trunk positioning can alter shoulder active range of motion and muscular activation, and to discuss the strategy of altering body positioning to enhance your patient-client functional shoulder outcome measures. Today we'll be highlighting reported outcomes by Miyakoshi et al. Examining the effect that different trunk positioning has on scapular muscular activity and shoulder kinematics. In accordance to the Oxford Center for Evidence-Based Medicine, this is a controlled experimental study and falls under the category of Level 2 evidence. Let's have a look here at study power, or it's sometimes written in articles, 1 minus beta. For this particular study, it was not reported. If you're not sure why you need to know this, let's take a brief minute to provide you a basic understanding as to why this is of importance to you, the consumer of research. Power could be verbalized as the following. If we repeatedly conducted this study over and over again, blank percentage of the time, it would result in the same findings that exist by those in the greater population. What researchers are attempting to do is to show how closely the sample studied represents the population at large. This allows for a greater generalization of the findings. Power can be affected by significance level, sample size, variability, and effect size. An acceptable study power is considered 0.8 or higher. This would indicate if we repeatedly conducted this study over and over again, 80% of the time, it would result in the same findings that exist by those in the greater population. As a consumer of research, it's important to caution that just because a study has a lower reported power, it does not mean the interventions utilized are of no benefit. Quite often, clinicians disregard studies composed of a lower number of participants due to the fact it may lead to less generalization. What's important to ask yourself here is, does the situation in which I want to apply the reported study outcome or outcomes to, does it call for generalization or individualization? To summarize things, I've taken and extracted the programming components that were utilized in this study. So you'll see that the authors recruited 14 healthy young men with a mean age of 24 plus or minus 1.9 years. Scapular kinematics and muscular activity during a standing 90-90 external rotation shoulder position were measured in 15 different trunk postures. The measures taken were EMG muscle activity and active external rotation that was held for 5 seconds at 1 rep to avoid fatigue. This was measured with a goniometer. In the column all the way to the right, we can see the various trunk positions that were utilized. So the control position, in which everything else was compared to, was an upright position. There were 4 sagittal positions in which we looked at maximum flexion, 20 degrees of flexion, maximum extension, 20 degrees of extension. Rotationally, we had a max contralateral rotation, 30 and 15 degrees of contralateral rotation, and a max ipsilateral rotation, and a 30 and 15 degree ipsilateral rotation. In the frontal plane, contralateral side bending at 30 degrees and 15 degrees, as well as ipsilateral side bending 30 and 15 degrees were also utilized. Now let's take a look at our statistical results. We'll begin with the findings for active shoulder external rotation resulting from the various trunk positioning. We can see by these two tables that contralateral rotation max and contralateral rotation to 30 degrees resulted in a decrease of shoulder active external rotation, and these were both statistically significant. Now let's have a look at the findings for muscular activation. This table illustrates 9 statistically significant increases in muscle activation across the trapezius infraspinatus, and serratus anterior as they relate to specific trunk positions. So you can see if we start with the upper trapezius here, the upper trapezius activates more when the trunk is placed in a position of ipsilateral rotation maximally. Same thing applies for the lower trapezius. This third column right here, IR30, indicates that the middle traps and the lower traps activate more when placed in that position. This contralateral side bending, we'll see activates the middle traps more when it's performed in 30 degrees of flexion. Flexion max, you get more of a activation of the lower trapezius as well as the infraspinatus. And then extension max and contralateral rotation max, you are going to get more serratus anterior activation. Clinical significance. Let's begin with effect size, or the magnitude of the difference. We took a look at some p-values earlier that tells us that a difference lies between the specific variables. Now we want to know how big those differences are. Findings for active shoulder external rotation and increase in muscular activation. What do we have? Okay, so no effect sizes were reported. If they were, the authors would be indicating the percentage of participants undergoing the intervention or a specific trunk position that would experience a similar outcome as those in the control group. So we don't want them having the same outcome. We want to show that they're different, basically, right? We don't want to be the same as the control group. We want to show that our intervention is doing something. Here's another way to illustrate it. If that didn't make sense, these two bell-shaped curves both represent a distribution. The salmon one we'll call the control group. The lilac one we'll call the a specific trunk position that was utilized. And then you have this purple in the middle where they overlap. Okay, when we're looking at this, the way that these two are graphed, it would be what we would call a Cohen's d, or a large effect size of 0.8. And this would indicate that 53% of the participants in the intervention, or one of the trunk positions, would experience the same outcome as those in the control group, which was the control position. But we don't want to know that. We want to know how many people this is going to work on. Okay, and what that comes down to is the area of non-overlap, or 47%. Please note that this is not what was found in the study. I'm just using the Cohen's d of 0.08, a large effect size, as an example. Let's also take a look at our confidence intervals. So what were the findings for active shoulder external rotation and increased muscular activation? Well, no 95% confidence intervals were reported. If they were, these confidence intervals tell you there's a 95% likelihood that the interval calculated contains the true population mean. So what does that mean clinically? Clinically, we could expect patient-client outcomes from the same demographic to fall within this range 95% of the time. When these are written up in research, you'll see that they'll say 95% CI. There'll be another number where I have mean listed there, and then they'll give you a range, a lower range limit and an upper range limit. And that is the range that you could expect your patient or client outcome from the same demographic to fall within 95% of the time. And we've come to the best part, our clinical gems.
What?
Our clinical gems?
What?
John, our clinical gems.
Okay!
So, we have an evidence-based truth that we're walking away with here from this article. And that is that trunk position alters active range of motion and muscle activation at the shoulder. If you go back and have a look at slide 7 and slide 8, you can get specific details on how these things are altered and what is taking place. So what type of strategy can we use to apply this new evidence-based truth to the body? First of all, we need to be aware of what each of these trunk positions will provide during the performance of active 90-90 shoulder external rotation. What will you use them for? Neuromuscular re-ed to reestablish force couples? Add them to a warm-up routine for more neurological priming? Or add them as a component to basic strength and power programming? Now, lastly, a quick moment of reflection here. You got to make sure that you're having an understanding of what these new truths can and cannot give you. We've gone through that pretty thoroughly in this video. So make sure that you're just not randomly applying this to any of your clients or patients. Have a reason for doing it. Design with a purpose. In order to determine how effective utilizing this is for the individuals that we're working with, you need to have some kind of measurable outcome that helps you assess your clinical effectiveness. And then lastly, how is all this programming going to help you and your patient work towards the greater goals that you have designed for them? Here at the channel, we're dedicated to establish and foster a positive interprofessional environment in which learning can occur regardless of your profession and or previous training. Please help us spread the word to your healthcare movement colleagues looking to incorporate more evidence-based research application into their own practice. As always, if you like what you see, please subscribe and join our YouTube channel community, where the number one goal is improving the lives of those we serve. A big thanks for hanging out with us today. See you in the next video.